Hi everyone, welcome to my new channel. Today, we're diving into a crucial topic, neuromyelitis optica spectrum disorder. If you or someone you know has been affected by this condition, or if you're simply curious to learn more, you're in the right place. I am a fourth-year medical student with an interest in neurology and would like to spread the information I have learned. In this video, I will talk about the key aspects of neuromyelitis optica spectrum disorder, its symptoms, causes, and potential treatments. If you want to support me, like this video and subscribe. Let's jump right in. Now, what exactly is neuromyelitis optica spectrum disorder? It's a rare autoimmune disease that impacts the optic nerves and spinal cord by causing inflammation and demyelination. Demyelination is a key term here. Picture the nerves in your body like electrical wires, and myelin is like the insulating covering around those wires. In neuromyelitis optica spectrum disorder, the body mistakenly attacks and damages this protective myelin sheath, leading to serious issues with nerve signaling. Distinguishing Nmosd from other demyelinating disorders, such as multiple sclerosis, is crucial for accurate diagnosis and tailored treatment. Back in 2004, a game changer was discovered in the world of neurology. Serum antibodies, IgG, that specifically target the water channel aquaporin 4, AQP4, were identified. This is crucial in distinguishing Nmosd from multiple sclerosis. The AQP4 channel, mainly found on astrocyte end feet, is a key player. During an attack, the antibodies target the AQP4 channel, triggering a cascade that leads to the destruction of astrocytes, secondary loss of oligodendrocytes, and demyelination. This disorder primarily affects middle-aged women, with the mean onset age around 40. The gender ratio is notable, with approximately 9 women affected for every 1 man. The annual incidence is around 0.5 to 0.8 cases per 1 million people, varying in different regions. In the USA alone, there's an estimate of 1,000 to 14,000 cases annually, but globally, it jumps to 24,000 to 350,000 cases worldwide. Unfortunately, recurrent attacks and event-related disability are common, with research indicating that 60 to 98% of patients will experience relapses with neurological disability. Now let's uncover the central pathogenic event in neuromyelitis optica spectrum disorder. The key player here is the entry of AQP4 IgG into the central nervous system through a damaged blood-brain barrier. When the blood-brain barrier is compromised, it allows AQP4 IgG to enter, triggering complement activation and granulocyte infiltration, ultimately leading to the death of astrocytes. AQP4 channels on astrocytes are highly expressed in critical areas like the optic nerve, spinal cord, brainstem, hypothalamus, and cerebral ventricles, playing a crucial role in maintaining water balance. Various factors, including stroke, traumatic brain injury, hypertensive encephalopathy, obesity, diabetes, cancer, alcoholism, acute liver injury, and other triggers of inflammatory states, can compromise the blood-brain barrier. Now, let's dive into the clinical features of Nmosd, breaking down the key points from this table. First up, optic neuritis. Patients experience a severe, painless decline in vision. Keep an eye out for potential optic nerve swelling at the onset, though it's not always present. Next on the list is transverse myelitis. This entails severe sensory and motor dysfunction. Watch out for painful spasms and pruritus. Recovery can be limited, and outcomes tend to be worse with extensive lesions. Moving on to area post-Rayma syndrome. Symptoms include nausea, vomiting, and hiccups. Interestingly, it might be misdiagnosed as a gastrointestinal problem. Approximately 58% of patients experience it, often preceding other relapses. Brainstem syndromes are also seen. Keep an eye out for various cranial nerve issues, such as hearing loss and gaze palsies, as well as diencephalic syndromes. Manifestations range from narcolepsy and hypothermia to syndrome of inappropriate antidiuretic hormone secretion, anorexia, somnolence, and obesity. When it comes to distribution among patients, 50% experience transverse myelitis, 35% deal with optic neuritis, 10% face both challenges. Continuing with cerebral syndromes. Look out for encephalopathy, hydrocephalus, and seizures. Proceeding to acute myopathy with hyperchemia. Recurrent hyperchemia with muscle pathology confirms organ involvement beyond the central nervous system as a component of NMOSD. Moving on to myeloradiculopathy, observe clinical features including weakness and sensory loss with lower motor neuron features. MRI may show evidence of cauda equina and spinal root enhancement. Exploring neuropsychiatric aspects. Recurrent major depressive disorder is the most commonly reported diagnosis, but patients may also experience mania, dysthymic disorder, anxiety, psychosis, and eating disorders. Suicide risk is reported to be higher in NMOSD than MS. Lastly, uveitis. Keep an eye out for vision loss, blurred vision, floaters, and photosensitivity due to inflammation of the uveal tract. Originally seen as a one-time occurrence, NMOSD is now recognized for recurrent events, mainly involving optic neuritis and transverse myelitis. About 92% of those with AQP4 IgG positive status experience relapses. Diagnosis depends on antibody status. AQP4 IgG positive, which requires one core clinical feature, or seronegative, which needs at least two core clinical features supported by MRI to rule out similar conditions. Core clinical characteristics include optic neuritis, acute transverse myelitis, area postrema syndrome, marked by unexplained hiccups, nausea, and vomiting, acute brainstem syndrome, symptomatic narcolepsy or acute diencephalic clinical syndrome with specific MRI findings, symptomatic cerebral syndrome with characteristic brain lesions. Breaking down the additional MRI requirements for seronegative neuromyelitis. Optica Spectrum Disorders. For acute optic neuritis, brain MRI should show either normal findings or only nonspecific white matter lesions. Alternatively, optic nerve MRI should reveal a T2 hyperintense lesion or a T1 weighted gadolinium-enhancing lesion covering more than half the optic nerve length or involving the optic chiasm. In cases of acute transverse myelitis, requires an associated intramedullary MRI lesion extending over 3 contiguous segments, LETM. Alternatively, 3 contiguous segments of focal spinal cord atrophy are needed in a patient with a history compatible with acute transverse myelitis. For area postrema syndrome, requires associated dorsal medulla/area postrema lesions. In instances of acute brainstem syndrome, requires associated periependymal brainstem lesions. When it comes to understanding neuromyelitis optic spectrum disorders, there are some key biomarkers that play a crucial role. First off, let's talk about AQP4 IgG seropositivity. This is a diagnostic marker, and it's worth noting that around 80% of individuals with NMOSD are seropositive for this. Moving on to other autoantibodies, especially those associated with conditions like systemic lupus, erythematosus, Sjogren's syndrome, and myasthenia gravis. These antibodies may not only support the diagnosis of NMOSD, but also come into play, particularly in cases where AQP4 IgG is not detected. Now, serum neurofilament light chain, a biomarker that correlates with disease activity, reflecting both clinical and MRI measures. It's a valuable indicator, providing insights into NMOSD relapse effects and even capturing the impact of medications. Let's not forget about serum glial fibrillary acidic protein, GFAP, a principal intermediate filament. Elevated levels in the cerebrospinal fluid and serum during NMOSD attacks are indicative of astrocyte injury, making it a significant diagnostic marker. And when it comes to tracking optic neuritis and its severity, optical coherence tomography (OCT) steps in. It includes markers like peripapillary retinal nerve fiber layer thickness, macular ganglion cell inner plexiform layer thickness, and microcystic macular edema. These elements help in optic neuritis relapse detection and follow-up, with changes reflecting the extent of axonal injury, especially when compared to optic neuritis in multiple sclerosis. When it comes to examining cerebrospinal fluid, CSF, in neuromyelitis optic spectrum disorders, NMOSD, there's a distinctive pattern. It typically shows a mixed pleocytosis, lymphocytes, neutrophils, and monocytes, with a median cell count of 19 cells ml, ranging from 6 to 380, and elevated protein, especially during relapses. Now, CSF oligoclonal bands are noteworthy. While common in multiple sclerosis, MS, they're rare in NMOSD, yet they might contribute to the diagnostic process. Lastly, glial fibrillary acidic protein, GFAP, a key component in astrocyte structure, shows elevated levels in both CSF and serum during NMOSD attacks. Higher CSF GFAP levels are reported during these episodes, predicting the presence of relapses. When interpreting the brain MRI findings in Neuromyelitis Optic Spectrum Disorders, NMOSD, the letters serve as a legend to a visual representation. A, B, C represent diencephalic lesions surrounding the third ventricles, including the thalamus, hypothalamus, and midbrain. D indicates a dorsal brainstem lesion adjacent to the fourth ventricle. E points to a linear medullary lesion contiguous with a cervical cord lesion. F highlights an edematous dorsal brainstem lesion involving the cerebellar peduncle, GHI, denote callosal lesions adjacent to the lateral ventricles. J. Tumefactive hemispheric white matter lesions. K. Long spindle-like or radial-shaped lesion along white matter tracts. L. Extensive and confluent hemispheric lesions with increased diffusivity on apparent diffusion coefficient maps, indicating vasogenic edema. M. Hemispheric lesions in the chronic phase showing cyst-like cavitary changes. N. O. Lesions affecting the corticospinal tract, involving the posterior limb of the internal capsule and cerebral peduncle. P. Longitudinally extensive lesion following the pyramidal tract. QR. Cloud-like and linear enhancement of the ependymal surface of the lateral ventricles. S. Meningeal enhancement. When interpreting spinal cord MRI findings in Neuromyelitis Optic Spectrum Disorders, NMOSD, specific features become apparent. Longitudinally extensive lesions are observed on sagittal T2 sequences. There's an extension of cervical cord lesions rostrally into the dorsal medulla. Subsequent cord atrophy is noticeable. In chronic longitudinally extensive transverse myelitis, LETM, there's a distinct discontinuity of lesions. In the realm of Neuromyelitis Optic Spectrum Disorders, NMOSD treatment, there has been a historical reliance on off-label use of conventional immunosuppressive therapies. These include rituximab, azathioprine, prednisone, and mycophenolate mofetil. However, recent advancements have shifted the landscape. New agents like eculizumab, satralizumab, and inebilizumab have undergone testing and trials, demonstrating efficacy in preventing future attacks. This marks a significant evolution in treatment strategies for NMOSD, moving towards more targeted and potentially effective options. Rituximab, a CD20 plus B lymphocyte monoclonal antibody, depletes B cells. Adverse effects are neutropenia, hypogammaglobulinemia, hepatitis, B reactivation, infections, infusion reactions, tumor lysis syndrome, mucocutaneous reactions, rare cases of progressive multifocal leukoencephalopathy. It is more effective in suppressing relapses than many off-label agents, including azathioprine and mycophenolate mofetil. Azathioprine disrupts DNA and RNA synthesis, inducing T-cell apoptosis. Adverse effects include neutropenia, leukopenia, pancytopenia, severe myelosuppression, opportunistic infections. It is inferior to rituximab and tocilizumab in NMOSD on relapses and disability progression. Mycophenolate mofetil inhibits inosine 5, monophosphate dehydrogenase. Adverse effects include neutropenia, leukopenia, pancytopenia, severe myelosuppression, opportunistic infections. It is inferior to rituximab and tocilizumab in NMOSD on relapses and disability progression. Methotrexate, a folic acid analog, increases adenosine release. Adverse effects include gastrointestinal symptoms, bone marrow depression, increased liver enzymes. Retrospective studies in NMOSD showed a decrease in annual relapse rates between 64% and 87%. Tocilizumab, an anti-interleukin-6 IL-6 receptor antagonist, suppresses upregulated IL-6, a key driver in NMOSD. Adverse effects include neutropenia, lymphopenia, pancytopenia, opportunistic infections, notably mycobacterial infections. TANGO trial demonstrated tocilizumab's safety and efficacy, showcasing longer time to relapse and a 78% reduction in 24-week confirmed disability progression compared to azathioprine. I4 immunoglobulin, IVIG, is a polyclonal IgG pooled from donors. Adverse effects include fever, headache, aseptic meningitis, thrombosis, anaphylaxis. IVG is suggested as an alternative for patients with contraindications to other treatments or for children, although data are limited. Eculizumab, satralizumab, and inebilizumab are the current approved maintenance therapies. Eculizumab inhibits complement C5, reducing AQP4 antibody formation. Adverse effects include headaches, leukopenia, lymphopenia, increased infection risk, especially meningococcal. Satralizumab, an IL-6 receptor antibody under development, blocks IL-6R and B-cell antibody production. Inebilizumab, a CD19 binding monoclonal antibody, decreases antibody production. Adverse effects include selective B-cell lymphopenia, rare neutropenia, leukopenia, 15% reduction in immunoglobulin levels, upper respiratory tract infections, bronchitis. In managing NMOSD, consider these key aspects. Focus on consuming antioxidants, omega-3 fatty acids, and essential nutrients for overall health. Keep up with regular physical activity to boost mood and well-being. Explore options like physical therapy, massage, or acupuncture to ease NMOSD-related pain. Improve mobility, strength, and coordination through targeted interventions. Seek support to navigate the emotional and mental challenges that come with living with a chronic condition. Optimizing NMOSD management involves tailoring drug combinations to individual needs. Autologous hematopoietic stem cell transplantation is considered as induction therapy post-severe attacks. Future agents are crucial not only for effective relapse management but also to restore neurologic function in chronic NMOSD cases. Ensuring access to newly approved NMOSD agents is vital, considering current therapy costs may limit benefits to select individuals. Over the last decade, scientific understanding of NMOSD has significantly progressed. Key discoveries identified immunologic targets, resulting in the approval of 3 therapies in 2019, a remarkable journey from bench to bedside. Prioritizing management now involves regenerative therapies for attack-induced disabilities. Ongoing efforts in scientific exploration, clinical rigor, and patient advocacy are striving to ensure universal access to safe and effective NMOSD therapies. These are my references, and if you enjoyed the content, don't forget to like, share, and subscribe. Thanks for tuning in.